All right, if everyone wants to start making it back to their seats, we'll get going with this next presentation. All right, well, I'm Sunny. I've been at On With Life since 2014. I'm a rehab clinical liaison. I started out on the nursing team, and I get the pleasure of introducing these lovely nursing team members. At the end here, we've got Brittany Anderson. She has been at On With Life since 2023. Then we've got Taylor Killstrom. Brittany Anderson is a CNA. Taylor Killstrom, also a CNA at On With Life. She's been a CNA for 8 years. She was actually with us about 5 years ago, but came back recently. Brittany Cook. Also a CNA. She's been at On With Life since 2021. She's a lead CNA and part of our spinal cord committee. And then we have Victoria Lowry. She is an LPN. She has been in our inpatient program since 2019. We have Bree Kappas. She has been at On With Life since 2016. She has worn many hats within On With Life. Started as a CNA, now as the RN on the floor. And then Ashley Jackson, she came to On With Life in 2020. She started as ADON and is now our Director of Nursing. So also been a part of the Dignity team for 3 years, and they're gonna take it away.
Well, I will say it's kind of hard to follow up with that really good presentation. It might be a little bit more stale than his. But we just kind of wanted to start off with a quote that we really live by down in the nursing department. It's, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. We really utilize this quote as a way to guide the way in which we interact and treat persons served. It's very important to us. And then the nursing unit is made up of many different moving parts: nurses, RNs, LPNs, management, charge nurse, certified medical assistant, CNA, rehab tech. And rehab tech is actually a very new position at OWL, and that's a position that's designed to help kind of keep the cares therapeutic for the person served, and they'll touch more on that later on in the presentation.
So talking about nursing cares, kind of what our nurses do on a daily basis. Obviously, you're going to do our daily assessments. We've got our med passes, but then we do a little bit more specialized things here with like wound cares. We're trained on how to put on wound vacs, how to manage those. We do incision management, trauma wounds, pressure injuries, and then we perform skin assessments every day. And we've worked with our physicians to come up with a set of interventions that we can go ahead and get started as soon as we find something. We work as respiratory therapists with trachs, doing nebulizers, CPT, suctioning. We also work with G-tubes, J-tubes, ostomies, JP drains. We do life vests, heart monitors, get some specialized training on that. We do PICCs, IVs, ports, and then also work as phlebotomists, getting those blood draws. Our charge nurse, which is a little bit newer for us, we implemented it about a year ago. And what we do is we have a fourth nurse on the floor that is a true charge nurse. So they take a lighter load. They're able to help complete more cares throughout the day. And kind of give a hand at being a resource to the other nurses and the CNAs on the floor. They help kind of take a look at the bigger picture throughout the shift, see how things are going, helps with better ratios, more quality time with person served, and then, better work-life balance with that.
And then this certified medication aid. We help with MedPass. We take some of the patient load off the nurses so they have more time to do their treatments. We can help with some minor treatments. We also can administer and assist with bowel programs. And then we're also just an extra set of hands to help on the floor or in the dining room or anywhere that just might need a little bit of extra hands-on. And then the CNAs can also assist the med aides or the nurses with the bowel program. We also do a glucose monitoring competency so that we have autonomy and we can help do blood sugars for the nurses. And then we also, with the daily getting up, we can do an extra skin check or when we're showering to make sure that we're not missing anything that we need to notify the nurse for or add to their treatment plan. And then we've really started putting in the work to do walking rounds so that whoever's leaving the shift and whoever's starting the shift is starting their shift on the best foot so that the person served get the best care that they can get.
And that leads us into teamwork. It's a big driving force down in the nursing unit and actually all of On With Life, but it's super important to us. It helps person-serve centered care, and that's just what we really want to go on at On With Life. And it just helps the different pieces and individualize our care for them. We take an interdisciplinary approach, so we have all different units working together with our nursing unit, and then it just helps us stay organized. We help check and change person served together during the walking rounds that she was talking about. That just helps the next, I guess, group have a better start, and just to help set up the person serve with a better day-to-day. That way, they're clean, they're organized, they're ready, and then therapy can come in and do their thing.
So personalizing care for our person served. I mean, how's it possible? Teamwork, obviously. So we utilize therapists, CNAs, the person-served care coordinators, kind of every nurse practitioner, everybody to figure out what's going to be best for our person served. We like to utilize the lifestyle surveys, so that kind of gives us an idea of what their life was like before, what they're interested in, what kind of drives them, so that therapy can incorporate that, but we can also incorporate that on the nursing unit. Obviously, if not everybody works an 8-to-5 job, especially in healthcare, we know that overnight jobs are definitely a thing that people do. And so if you've worked overnight for the last 30 years and then you come in and you have to try and change your lifestyle to fit this 8-to-5 model of therapy, that's really hard. So we try our best to try and accommodate changing the medication pastimes or changing what time they start therapy during the day, what time we get them up for the day, just to kind of help them feel more comfortable and feel more at home. That'll kind of take us into family training and education for our person served. So we like to try and empower people to get the most out of this and do the most that they can for themselves. Give them independence, get them ready for discharge, increase their accountability, and increase their self-satisfaction and their self-worth. If you go from being completely independent all of your life, and now all of a sudden you're completely dependent upon someone, that can take a big toll mentally, and to be able to give them back some of that control and some of that independence can go a long way. So how we do it is we'll go through and kind of figure out, so say they've got G-tube cares, for instance. We're gonna go through, set up, how does that look, explain the entire process to them, explain what they need to be looking for, and then the next step will be showing them. So demonstrating how those G-tube cares are gonna be done, showing them anything they need to be looking out for, and then doing it with them. And then watching them do it, make sure that we're answering any questions they have, and then they can be independent with that.
So just implementation and takeaways is I would just make sure to individualize their care. That's just really important, and that's like what she said, that's what we try to do so they can have the best possible scenario going home. And then how can you better personalize the care for the person served or patient resident when they go home or in your facility? And just what does success look like for you? It may look different for us than it does to other facilities or areas. And how do your patients and families feel? Do they feel prepared? Do your families feel supported? Do the person served feel supported? And are they heard? And then this goes back to our quote again. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel.
So next, we're going to just hit on our orientation process at On With Life. So we are a very unique facility, and we come into contact with persons served who have had unique injuries or diagnoses. So because of this, we have a very thorough orientation process to make sure that our staff is completely prepared and confident in their roles. So our orientation process includes rehab and neurological information that occurs annually. In other words, we call this our therapy competencies. We have our general orientation, which is hosted every month for all of our new hires that have been hired for that month. The preceptor class is semi-annual for all of our nursing staff, and this class is just designed to promote fellow leaders. We can do more peer-to-peer information between each other. The nursing skills fair we host, the nursing leadership comes up with this every spring for all of our nursing staff as well. That's more hands-on. And then we have our staff competencies. These are all completed with all staff, and that's when we're practicing new skills, such as wound vac changes or applications of wound vacs.
And then we have the rehab and the neuro orientation. We have speech comes in, and then during the annual therapy competencies, we have a speech language pathologist speak that does different kinds of aphasia, dysphagia, diet levels. It's always a good refresher for the senior staff, and it's very beneficial for the newer staff. Our clinical counselor joins in to speak about cognition, brain injury basics, neuro challenges, such as Dignity Team and strategies for these challenges, and we'll talk about Dignity Team. And then we end the day doing transfer training with the therapists. We learn range of motion, how to run lifts, how to apply splints, body mechanics, just making sure that we're all comfortable and able to do it in the safest way possible for the person served. And then we all just have to be signed off. Therapists have to make sure that we're doing it correctly, and then we get signed off on it.
So for onboarding and general orientation is about 4 hours of information. We do a day of this. It's geared more towards On With Life as a whole. So we start off by talking about our culture, the quality of care that we are representing as a staff. We have our interpersonal skills. We go over person-served information, and then just the ability to communicate with our person served the best way possible. The CEO, Jean, actually comes and introduces herself during this. She introduces the principals. All of our department heads come and talk about their roles and experiences, so you get an introduction to everyone right there. We have Liz, who's actually a former person served. She comes and talks about her experience inpatient, and now she is actually a staff member, so she is able to be more empathetic towards some of our person served and a role model for most of the younger person served as well, which is really nice to see. Our clinical counselor talks about brain injury, spinal cord basics, neurological challenges that we may face. And then during training, we schedule new hires with therapists so that they can gain better knowledge of their roles with the person served. Our orientation process includes a very thorough checklist. The trainer on staff will go over that with the new staff. It includes a checklist, and then the online modules through LMS. They just get an extra training with that. You have the ability to touch base with leadership as well during your entire orientation process. So you can check in, you can say what's going well, what's not going well. You can say, hey, I really have some concerns about this, or maybe I just need a little bit more time in training, and we definitely can do that. Our preceptor class, we hold this class semi-annually. It's devoted to providing the tools to becoming a better mentor and leader, so we aim this class to help staff guide newer staff. During this class, we approach crucial conversations, tips and tricks on how to approach that with another staff member so that you can discuss these things before going to leadership or HR or things like that. So we're just trying to nip it in the bud where we can at the very beginning. We try to encourage staff to address the issue or situation in the moment, and then HR comes to this class and they discuss On With Life's culture and the norms. Our clinical counselor joins the class, addresses different family dynamics that we may come into contact with, and person served. And then throughout the class, we actually do different case studies about situations and how to address things in the moment. And this just makes staff come out of their comfort zone a little bit more, which is really nice to see.
And then we do the nursing skills fair. It's skills for the nurses and the CNAs. It's held every spring, and it's usually split up, so certain days nurses come, certain days CNA comes, and then towards the end of the week, we'll kind of put the both together. there's different stations. They'll have G-tube care, trach care, wound care, restraint application, IV pick skills, catheterizing, a mock med pass, and then a mock code. Within the stations, we're asked questions based off the policies. So for example, how often should we be changing a continuous tube feed? Based on if it's a nurse or a CNA, they tweak the cares so that they're familiar with them. For example, a nurse will have to show how to cath a person, and then a CNA will have to show how to do the catheter cares. And then for staff competencies, during the training process, staff complete competencies so that once they are on their own, they're more comfortable and they can complete the tasks for the day-to-day basis. CNAs are trained to obtain blood sugars, and nurses are trained to apply and change wound vacs. And then ways for implementation, we ask for feedback from staff. What do the staff need? What do they want? Having appropriate tools. The orientation checklists are great because then if you aren't feeling comfortable, you can go and get more education on it, or you can move on to the next one. And then having a lot of hands-on opportunity, being able to learn hands-on how to do things always works better than just reading about it.
So next we'll go into the nursing department overview. So every month we have nursing meetings that we are supposed to attend. If we can in person, we always do online as well. So if someone's on maternity leave, someone's sick, that sort of thing, or they're working during the times, they can do it online. These monthly meetings are nurses and CNAs put together, and then we also have spinal cord injury topics where our spinal cord spinal cord coordinator, Sam, comes to our nursing meetings to hit key points on spinal cord injuries. Because this is fairly new, we just want to be very educated, and she does really well at explaining and telling us topics and giving us different types of scenarios and gives us implementation options. And then we also do pop-up skills 101, so kind of similar to what they have, but if we are feeling kind of funky, we don't feel comfortable doing catheter cares or changing catheter, you're new to the facility, what we do is we ask, a staff member such as like Ashley, our DON, hey, can you watch me do this so we are doing it correct to the policy? And that just helps everyone stay on the same page and decrease UTIs, infections, all of the sorts.
So in the nursing department, we have huddles. We hold these twice a day and then once at night. During these huddles, it's for the whole entire staff that's on at that time to get together and discuss how our day's going to go. We have discussions about process changes, our census for the day, if we have any admits or discharges for the day, our safety cross, which is med errors or falls. We try to discuss those in the moment and try to deter that from happening again. We have our staff shout-outs, so anyone in the room can just shout out a different staff member for, examples. Someone helped me on the hall this morning because someone was late. Anything like that, we just want to shout out and give that person the kudos that they deserve. We discuss our dignity plans, which will hit a really big amount of dignity at the end of this. And then therapy is actually invited to those huddles so they can discuss new changes for our current person served or discuss falls, and then they try to work with us together as a team to ensure safety and discuss ways that we may be able to prevent another fall in the future.
And then we have staffing ratios. This is different between nurses and CNAs. We go by acuity points, so each person that comes into our facility is kind of graded on a scale of acuity points, and that's based on, for nurses, it'd be G-tubes, trachs, IVs, restraints. If they have a lot of behaviors that we're trying to help them get through, or their family members, they get a point for each thing, and then based on the points, we will do different halls for different people, and that way one nurse doesn't have a very high caseload compared to the other one. And then we also have, with the acuity system, it helps us just manage our day better. It just really helps the person served have better care if a nurse isn't ran thin or a CNA down one hall compared to the other. So that just kind of gets us on with CNA's acuity.
CNA acuity is newer to us. We did not used to do acuity for CNAs, but we have decided that that's probably our best bet since the nursing acuity works so well. It is more on a physical base. So, for example, if someone is a Hoyer lift, their acuity points are going to be a little bit more because they're more dependent on us, versus if someone is more independent, they aren't going to need as much help with their cares. So their acuity points will look a little bit different. We actually have a new rehabilitation tech. That is a newer position at On With Life. That tech helps with cares in therapy and in nursing, so it makes it more therapeutic. So day-to-day for a rehab tech is going to be starting off in the nursing department. They will help with showers, range of motion, getting people up with their splints on and ready for the day. And then halfway through their day, they will transition down to our therapy department, and they will help with range of motion there, splinting, just so that we are all working together as a team in the same building, which is really nice. We have monthly education, so this is for all staff to complete. Education is over anything brain injury related, any policy changes, any new procedures, any new cares that we're administering. This is really helpful. It just keeps us on our toes, make sure that we know what we're doing as a staff. We're signed off on this, and we have a quiz that's completed, and the quiz is turned into our leadership, and they actually give it back to us and let us know, what we got wrong, what we didn't, and we try to discuss it as a team. This is the best part. We have celebrations. So we have karaoke Fridays for our person served in our nursing department. I host quite a few times. Ashley, our DON, hosts as well. This is a great way to incorporate therapy. So we help them stand, we help them play instruments, they can hold the microphone, they can sing. It's just, we're trying to do as much as possible and make it as therapeutic as possible for their day. We have our staff appreciation lunches. These are held monthly, facility-wide. So you get company-wide announcements, like process changes. For example, Jean touched on our new Polk City build. That was one that we discussed at one of these staff appreciation lunches. And they also go over anyone that's having an anniversary as well, which is nice. We have our graduation parties for person served. So whenever a person served is graduating from our inpatient program, if they're going to outpatient, if they're going home, if they're going to a different facility, we do a graduation party, and staff and the person served and their family attend. We celebrate all of their accomplishments, and then therapy and nursing get to stand up and speak about certain aspects of their care while they were with us, and it's just really to make them feel like we made a difference and that they made a difference, and I can honestly say I cry at every single one, so.
So now onto the accommodations. So a big part of why On With Life is unique is our commitment to tailoring accommodations to fit the different lifestyles and preferences of each individual we serve, as we kind of mentioned before. So starting off, a lifestyle survey is filled out on admission with each person served or family member to help guide our staff on creating a personalized care plan. Also on admission, we give our person served the option to choose their shower preference. As I'm sure some of you prefer to shower in the morning and some at night, our person served also have that preference. So we like to be able to give them that option if they do prefer a certain time. And then Bree had mentioned this before, but our medication passes can also be personalized for each person served. For example, if John was an overnight truck driver for 25 years, he probably isn't going to want to take his meds at 7 a.m. And like Susie, who worked at a bank from 9 to 5, probably doesn't want her meds at 10 p.m. So we have to make it, as normal to their life as possible. Another thing, we also encourage reorganization of furniture in person serve rooms to make them feel a little more at home. So person serve are allowed to add decorations, pictures, whatever it is that makes them feel more like home. And we can add things like a recliner if that's something they are used to using at home. The last thing is On With Life also offers on-site housing, which Jean mentioned this morning, to family members of person served. This enables families to remain closely involved in their loved one's care and recovery process and is honestly utilized very often. So it'll be exciting to have another 2 houses on the property.
And implementation or takeaways, I would say huddles would be the big one, and just, are you doing them in your facility? Do you think they'd be beneficial for you? They definitely have been for us to keep us all together. And do you feel like your team is in the know? Do they understand what's going on down in therapy, in nursing department, in the whole facility, or are they just there to work? We don't want that. We want them to feel like a family involved. And then would huddles help you be more organized?
Okay, now on to our nursing team rounds. So On With Life knows that our population of individuals is unique. So we have created a variety of different rounds or meetings to be able to personalize the care we give as much as possible in order to help our person served get on with their life. So shown above are the different rounds the nursing team is involved in, and in the next few slides, we will go over the importance of each one.
The first one we're going to talk about is mega rounds. Mega rounds is kind of an all-encompassing round for us. It happens once a week. It involves everybody that we can get in there. So we've got social work, person-served care coordinators, case management, nurse practitioner, therapy, and then floor nurses. This is really, it's a check-in for everybody to see how is each person served doing, what barriers do they have to discharge, when is their discharge, where's their plan to discharge, and just kind of make sure that everybody in the team is aware of what we're working towards for that person served over the next week. Nursing rounds happen the other 4 days of the week and include just the person-served care coordinators, the floor nurse, and the nurse practitioner. We usually will just sit down every day and talk for 15 minutes, 20 minutes, whatever, go through all the person served that we're taking care of as a floor nurse that day and say what's going well, what's not going well, what new things came up, just so everybody can be involved and the nurse practitioner and the person served care coordinators can make sure that all their needs are being met.
Okay, now we have our wound rounds. So the wound rounds is fairly new to On With Life, so we're still kind of working on different ideas. But once a week, our care coordinators, our nurse practitioner, spinal cord coordinator, clinical educator, the dietitian, and a member of therapy meet with the person served who have wounds to evaluate the healing progress of those wounds. So they will compare pictures from previous weeks and take new pictures, and if needed, they will implement different interventions like a repositioning schedule or adding some type of nutritional supplementation to promote healing and prevent wounds from worsening. During the wound rounds, the team will also decide if and when hydrotherapy is appropriate, and I think these new rounds are really cool because they meet with the person served. So the person served has a say in their care and get to know what's going on, without it being behind their back. So next is our Rehab 16 rounds. Rehab 16 rounds is a collaborative partnership between our therapy team and our CNAs. So the concept revolves around ensuring that our person served receive a total of 16 hours of therapy opportunity each day between their scheduled sessions and waking hours. These weekly rounds serve as a platform for therapy and the CNAs to combine their efforts in enhancing the well-being of our person served. So we focus on things like transfers, toileting, dressing, ambulation, etc. And then CNAs provide feedback to the therapy team, offering insights into what strategies are effective and what areas might require more adjustment. So Therapy takes that information and then communicates any modifications or updates, and updates the entire interdisciplinary team to ensure that everyone is on the same page.
And then I'll just kind of briefly touch on the rehab team meetings. It's more so therapy-based, but the person-served care coordinators and the nurse practitioner are involved with that, along with case managers, our PMR provider, and our clinical counselor. And again, they're meeting weekly to go over person-served, how they're doing in therapy, what can we be adding in on a medical standpoint to help them meet their goals. But it's more so therapy focused on that one.
Okay, so implementation and takeaways. So each of these meetings that we discussed serves a crucial role in facilitating communication between staff and across all departments. So the purpose of these rounds is to ensure that we cover all aspects of person-served care. Given that the staff members participate in different rounds, our lovely care coordinators actually take the responsibility to send out daily updates to both staff and providers to ensure that all of our information is communicated effectively. How can you implement different types of rounds in your facility? And the end. Just kidding. Sorry.
So actually, I'm going to pause for a little bit just because I know you guys heard a lot of information from the nursing team. We're actually going to, in a little bit, dig a little bit deeper into Dignity team. But before I do that, I wanted to open up to see if anybody had any questions for the nursing team on any of the ideas or concepts that they talked about already. Yeah. Oh, we have a. I got it. I got it. Hi. You don't want to talk in it?
It's okay.
You can do it.
Can you tell me more about the Rehab 16 that you guys were mentioning and how you're saying that they have the opportunity for like 16 hours of like, I don't know how you phrased it or like what that looks like, the coordination between therapy and CNAs? Because I know for us, like you said, we're working that 8 to 5 therapy life, but then what's happening after when we're gone?
So that's kind of, okay, so the 16 hours of opportunity, so if you take the 24 hours in a day and you say each person served is going to sleep for 8 hours, that leaves us 16 hours left in the day. Obviously, therapy is not there all day. They're there, say, like 7 to 4 or 8 to 5, whatever it may be. Who's providing therapy the rest of the time? And so that's why they've kind of partnered up more so with the CNA team to talk with them and help better look at like what's going well with transfers, right? Because like who's doing the majority of the transfers most of the day? Therapists see them for a half hour or an hour at a time, but the CNAs are in there, in and out, and nurses are in there all day long. So they really have more information on like, yeah, they are doing really great with this stand pivot transfer in the morning, but by the time we get to bedtime, they're struggling, and it's more of like a 2 assist instead of a 1 assist stand pivot. And so the partnership between the two of them is just more so looking at how can we make every interaction that we have with the person served as therapeutic as possible throughout the entirety of the 16 hours that we have available to them, if that answers your question. Kind
Yes.
of. That's so the therapist will meet with the CNAs weekly and kind of go through like, this is what their current orders are. How do you think they're going? And that's when the CNAs and the nursing staff can provide, like, I think transfers are going really great down here. So I think that we could maybe push it. Like, can we trial doing a stand pivot transfer instead of like a Sarah-Lift transfer or a Lumex transfer or something like that, and kind of help keep the process moving forward, just because I see them more often. Yeah, weekly, yep.
Also, something that I think is worth mentioning is the therapists take turns coming down and meeting with the nursing staff. And that also helps, our CNAs get more comfortable with the therapy team. Helps kind of create that relationship and that bond. Because, some CNAs may not have exposure to all the therapists all the time. So kind of rotating and getting different therapists down and meeting with different CNA staff is really important too for building that relationship between our two teams. I think kind of like Bree mentioned, the Rehab 16 thought is there's an opportunity for 16 hours of therapy each day. So how can we, even down in the nursing unit, make their day as therapeutic as possible, even when they're not in an actual session? So, yeah. Hi. Oh, okay. I'll come to you.
When you talked about your acuity scoring, is that something you have built into the medical, like into the charting, or does your lead nurse come up with that? And was it something you built yourself?
The answer to that is yes, both. So it's something that we have developed on the nursing side, and we tweak as we need to, like as we get different things coming in, but we've also now interfaced that into our daily assessments as well, so that it can track that there as well. So we're still at the part where it's not quite perfect yet, the interface of the two. So we do our acuity ourselves, but then it also interfaces as well. So we're trying to get that better interfaced, I guess.
Does that answer your question? All right. I was curious, the case managers that are involved in your meetings and stuff, are they on staff? Are they from community, or where are they from?
Yeah, they're our staff members.
Okay.
So we split our person served as they come into two different teams, and so we've got a 28-bed facility, so it's about half and half. And so they'll take half of the person served load, and they take care of managing any of their appointments, any of the daily needs that they have, and then getting their discharge planned as well.
Okay, that's what I was wondering. Do
Yep.
they also reach out to like community providers to help with the discharge planning, because there's so much that goes with that?
Yeah. Getting like their primary care provider set up on discharge, and like who they're going to be following up with after
good.
they leave us, any outpatient, anything like that.
Great,
Rehab.
okay.
Yep.
Thank you.
One here, and then Kim, there's, over there.
So my question's kind of specific about processes. I'm an SLP, and the unit I'm on, they, nursing staff, everyone, we're struggling with oral cares. Okay, so oral cares just being that anyone that's not on swallowing precautions should have a clean mouth anyways. But in addition to that, people that are on like dysphagia water protocol, there's days that I walk in and it's 11 o'clock in the morning, and I want to work with them on ice chips for swallowing, and the oral cares haven't been done. We have rolled out a lot of education across our PCTs and nursing staff, et cetera, a whole bunch of other things. But what do you guys do at On With Life to ensure that the oral cares are getting done as a team? Do you have a solution?
I don't think there's a clear-cut solution for oral cares. Unfortunately, I would love to have that. I will say that nursing staff and CNAs, we work together as a team for oral cares. So if someone is MPO, oral cares every 2 hours, the nurses are checking that. It's popping up on their charting. The CNAs also are doing that, so it's popping up on our charting, so that everyone is working together as a whole to get it done. Now, I will say that with brain injuries and some of the injuries that we come across, some people do not like their mouths cleaned, and they don't want to open their mouths for those oral cares. We get to the point where it's like we try our best to get as much as we can get done in that time span that we have, but also we try to utilize oral cares without that time span. So if we're doing a shower and they're more relaxed, or we're getting them ready for bed, or they're watching a movie with us, we are going to try and do those oral cares as much as we possibly can, because it's so important, and we want them to have a clean mouth just for all of the aesthetic as well.
I was going to say, I think the biggest piece to that is what Brittany mentioned, the like oral cares on our charting, on the nurses' charting, and on their charting. Because like I know as a nurse for me, I usually check in with the CNAs, like, did you guys get that completed yet? If not, then I'm gonna go and get that completed.
And part of our issue is things weren't even getting charted. So, you know, if it's not charted, so it's not in the chart. So if it's not charted, technically it was not done. Right.
We also have, at the end of the week, as the lead, I am printing out missing documentation and charting that wasn't done. And we are going back to those staff members and saying like, you know, we noticed that this wasn't charted. Was there a reason that we're not doing that? So then we're holding everyone accountable as well, which is really nice. So then we can talk to that person and say like, was this person having a rough day as a person served? Did you not have the opportunity to do it? Did you ask, you know, the nurse to help you? So we're doing that at the end of the week too, so we can go over documentation, and we're trying to hold all staff accountable and make sure that even if it's not getting done, you're not just leaving it empty as well.
One thing I do want to mention a little bit too is, you know, we have really great therapists at On With Life, and we have good relationships with our therapists. And so if a speech therapist is noticing that oral cares aren't, you know, could be done better, they're quick to communicate that with our team. So that way we know, hey, this is something that we're missing and we need to do a better job with this individual. So I think too, it's just communication and everybody being open on, hey, you know, I'm doing my best, but I missed this one thing and I could have done that better. And owning that also and working to improve, because, you know, we're all human, and there are some days in the nursing unit it gets busy, and so having that open communication with our therapy team and being able to hear, you know, we could have done better in this area is also really important for us too.
I also want to add that we audit. So she is lead CNA. She likes to audit people, and then our
I like you.
yes. Well, and as like charge nurse and the person that's in charge on the floor, we make sure too, it's our job to make sure like, hey, if you don't have time, can you come to us so we can do it? Or like Ashley or the team leads of our department, they will do those one-on-one sessions. Like maybe someone doesn't feel that comfortable doing oral cares, especially with brain injuries where maybe you need another person to help distract them while you do oral cares. And they're just kind of afraid to bring that up. So the one-on-one sessions are very important as well.
Yeah. Okay. Sorry.
One more question before we move to the next part after this?
Yeah. Yep. One more.
I just actually have two questions. So we use a dry erase board in our patient's room, and we write down how, as therapists, how the patients move. And so we make the expectations that the nursing techs would see that. So we don't have that nursing tech therapist meeting every week. Do you guys have dry erase boards that communicate that? So you do that in addition?
Yes.
It's more of a conversation about which patients are more of a problem, more difficult?
Yeah, it's just more, so it just provides that dialogue between the nursing team and the therapist on, like I said before, like if somebody's moving really well for you guys in therapy during the day, that's fantastic. But then if you get to bedtime and they're basically a Sarah lift, I feel like that's probably a conversation that needs to be had with you guys, right? So like what can we be doing differently, or how can we change things to help make things a little bit more therapeutic for this person?
And we also end up having the nursing techs use a lot of lifts more than what therapy does. You guys see that as well?
Yes.
Because of all the
Yeah.
instructions you give? Okay.
Yep.
Okay. So I'm going to talk, during the previous presentations, you guys have heard discussion about dignity and a little bit of mention of dignity team. So what I'm going to do is hold the clicker and the mic. Bear with me. We'll figure it out. Okay. I'm going to talk about what dignity team is at On With Life. So the first thing that I want to talk about, I just want to go over the definition of dignity, because I think it's really important to understand what dignity means before we go into discussing how we apply that at On With Life. So dignity is the state or quality of being worthy of honor and respect. And I think some of this ties into the quote that Victoria shared earlier in the presentation, but we really want to make sure that we are focusing on how we are making our person served feel every day, because that's really what they're going to take away, is how we treat them and how we interact with them on a day-to-day basis. But treating others, especially our person served, with dignity during every interaction is at the forefront of what we do. And really focusing on dignity in every single interaction is essential to be able to build trust with our person served. Dignity is also especially important to consider when we're working with neurobehavioral challenges. So what is Dignity Team? It is actually a group of individuals who meet on a regular basis to discuss neurobehavioral challenges that we're seeing on the unit. The goal is actually to meet the person served where they're at. We don't want to try and change the person. We don't want to try and change the behavior. But instead we look at how can our staff adapt their approach and their strategies to be able to meet that person where they're at during their challenge. We're very intentional with our language when we are discussing person served during Dignity Team, and we're careful to not attribute any behaviors to that person. And how we do that when we're discussing challenges that we see is, instead of saying, for example, this person is being physically aggressive, we're going to say we are seeing physical aggression. And I think it's really important when we're discussing that to focus on that language and create, or I guess, make sure that we're speaking of our person served in a dignified manner, but also that we're sharing with staff that the behaviors we're seeing are not intentional. It's a part of their injury. They're not able to control those, and so that person is not intentionally doing or saying these things. This is a part of their injury, and this is something that we need to really change our approach to make sure that they're as safe and as comfortable as they can be while they're with us. Our goal of the meeting is to remain solution-focused, which sometimes can be really hard. If you have experienced or witnessed neurobehavioral challenges, you know that it's distressing for the person served. It's distressing for their family. If you can imagine your loved one having a brain injury or going through a traumatic event, and all of a sudden their personality is completely different than the person that you knew before, that can be really, really distressing for people. And it also can be hard for staff to learn to navigate, because we're meeting this person for the first time, we're trying to get to know them, but we're also seeing some of these challenges, and we're also learning how to navigate those. So we really work together as a team to make sure that we have a unified approach when we're working with that. Okay, so who attends? It's really important that we have a handful of different team members, because we can gain different perspectives on a neurobehavioral challenge just by talking with different key members that have interacted with the person served. So our clinical counselor attends. We have a therapy team lead along with 1 to 2 other therapists that will attend. From the nursing department, I attend those to represent nursing leadership, but we also will have a floor nurse and a floor CNA attend as well. From a therapy and a nursing perspective, we'll typically see neurobehavioral challenges the most when our person served are working with our CNAs or with our therapists. And the primary reason for that is because a lot of our folks, we're in their personal space. We're doing personal cares and therapies. We're getting really, really close and working intimately with the person served. So that's when we tend to see neurobehavioral challenges the most. So it's really important to have our CNAs and our nurses and therapy team members there, because they can provide us with insight on how that person is doing when we're in their personal space. Our social workers attend as well, and our nurse practitioner. Sometimes we can take a look at, if they're on any medications, do we need to adjust anything to help them be more comfortable while they're with us? There are some other staff that we may ask to join if we know that a certain therapist was with a person served when a neurobehavioral challenge event happened. We might ask them to join so we can gain a little bit more insight into what happened during that time frame. We may also invite a family member to join us during the Dignity team. And we do that for a couple different reasons. One, it helps us gain insight into who that person was before their injury, and learning more about the person served, the things that they enjoyed prior to their injury, helps us gain chips when we're working with that person. Additionally, as I mentioned, neurobehavioral challenges can be really hard for families to understand and to process. So involving them in that conversation helps to reassure them that what they're seeing is normal and expected after a brain injury. And it also gives them reassurance that we as a team are aware of the challenge and that we're working together to help them. One other thing to mention is that our Dignity team members take additional training. We are all MANT trained, and MANT is a behavioral training program. Flip, click. It's actually the name, oh, sorry. Hi. I'm like, I don't know who asked that. It's actually the name of the individual who created the program. Sorry, I couldn't hear. I'm actually not sure. Jess, do you know? Jess is one of our MANT trainers, so I'm looking to her right now. I'm not sure. What I do know about MANT is that it focuses a lot on de-escalation and redirection techniques. There is a physical component that you learn. We don't have to use any, physical components at On With Life. We have not had to. I like to think that our staff are very skilled in de-escalating and redirecting to where we don't have to use those other interventions. But I'm not sure on the Moab question. I can find out, though. Okay. Okay, so as far as meeting layout goes, the first thing, of course, that we're going to discuss is what challenge are we seeing? And that could be a variety of different things. Typically, we'll see resistance to cares. So again, people don't like you being in their bubble or in their space. We might also see some agitation, some lability, disinhibition as well. So what is that challenge? The next thing to really look at is what preceded that neurobehavioral challenge. Are there certain triggers that happened that had the neurobehavioral challenge as the response? And sometimes that might just be for somebody, they're not able to communicate their needs. Maybe they need to go to the restroom and they're not able to communicate that, and our staff aren't understanding what they need. And then somebody gets agitated. I would respond the same way if I wasn't able to communicate my needs. So really just looking at, what is happening that is triggering that response. After that, we discuss approach. So I think it's important, this is really where the staff feedback becomes important, because our staff are pretty skilled for the most part, where if they see a neurobehavioral challenge, they have some tools in their toolbox that they can start using. But it helps to know what's working and what's not working. There are times where we come to the meeting and we say, okay, I've tried this, this, and this. They all didn't work. And that's where, as a team, we can sit and look at, okay, here's something else we can try. We tend to look at previous situations as well. If we have a former person served who had a similar neurobehavioral challenge, we might look to that situation and say, okay, what did we do here and what did we learn from this situation? And that at least gives us a starting point to be able to get a plan together for that individual. After that, our plan gets put together, we type it up, and that plan can be anything from approach to different strategies. We like to use a lot of scripts for staff, so So that way we have a consistent message amongst all of our staff. And so we put that plan together, and that is sent out to all of the team members. The most important thing is making sure that we have that unified approach. We are all working with that person served and responding to that neurobehavioral challenge in the same manner. That has been the most effective for us in making that person served more comfortable, and then also giving our staff tools to be successful and have successful interactions with that person served as well. One other thing with the plan, having consistency amongst staff also helps model that for families as well. I think a lot of our families, when they're seeing neurobehavioral challenges, again, that can be really hard for them. They may not know how to respond appropriately in those situations. So having our staff have consistent responses also helps model those approaches and strategies for family members. Knowing that neurobehavioral challenges can change frequently, we do meet once a week and address, okay, how did this last week go? Did these strategies and approaches work? If not, what should we try next? So we meet often to discuss that and regroup. I'm talking more than I thought I would, so I'm sorry. Some examples. So I'll just cover some common examples that we see at On With Life. So emergence. We work with persons served who are in the disorders of consciousness categories, and as they emerge from that, we might start to see a variety of different behaviors. When working with these individuals, our common approach is going to just reduce stimulation for those individuals. So making sure that when we're interacting with those persons served, we are speaking in a soft and calm voice. We want to give them breaks in between therapy sessions. So taking them back to their room, providing reduced noise, making sure that their lights are dim, just giving them time to relax in between the busyness of the day is really important. Also, one thing that we talk about a lot in our team is big potatoes, small potatoes. So also looking at, is this something that I need to do right now, or can I give this person a break and attempt this later? Disinhibition. We often see persons served after brain injury say things that they don't mean to say, or say things that they wouldn't normally say. Sometimes that comes out in sexually inappropriate comments. Sometimes that comes out in foul language. It can really just vary person to person. For us, quickly redirecting that person and moving to a different topic seems to be the most helpful. Working with a variety of different people, we really want to make sure that our staff know that if somebody says something that might be inappropriate, also to not laugh, which I know seems silly, but when you get caught off guard, sometimes your first response is to giggle. And so really making sure that our staff are not giggling or laughing when persons served are saying things that they may not normally say. Resistance to cares or care refusals are also really common, again, because our person served may not, even though we're explaining what we're doing, they may not understand why we're, in their personal space. They may not understand why we're doing personal cares with them. So again, with this situation, picking big potatoes versus small potatoes, is this something that needs to be done right now? If it does, really making sure that we're giving a lot of verbal prep before we're doing anything with that person served can help. Last but not least, emotional lability, and this kind of goes with some similar examples, but making sure that we're not matching the emotion, but we're quickly redirecting that person served. Some other considerations that we may need to implement is just alternating staff. Learning which person served respond to which staff the best. Sometimes persons served don't respond to males very well, or other times they respond to males the best. Some persons served may not respond as well to younger staff. So really looking at what our staffing considerations are and how we can adjust our staffing to meet the needs of that person as well. I have a couple more minutes. Okay, the very last thing that I want to talk about is family plans. And this is something that has kind of evolved over the last couple of years at On With Life. But we recognize that brain injury can be a very traumatic experience, not just for the person, but for the families as well. And we see a lot of family members come in that need just additional support and resources. So we have begun discussing that at Dignity Team as well. And really the purpose for this is to help identify what family members may need additional support early on in their stay. We will identify point people for that family member. So we would introduce them to their social worker, their care coordinator. I'll typically meet with them right away. And we do that to make sure that they know who they can go to, and they also know that we're there to support them. Thank you. It can be also harder for families to implement strategies just because this is very new to them. So making sure that we're working with them and providing that extra education when needed is important too. Okay. Any questions about On With Life's Dignity Team or neurobehavioral management?
This is Jean. I just
Hi, Jean.
wanted to thank you all for presenting today. And I was sitting here thinking, how many rehabilitation conferences have you been to where you've had a full-blown nursing presentation, where nursing is acknowledged and recognized as a vital part of the rehabilitation team? I can't imagine it being like that, but I've seen it like that in the past. And that's all I wanted to say. Thank you.
Thank you.
Thank you for being a part of our team.
Thank you. Oh.
All right, where's the question?
Oh, hi.
Left.
Should I
Raise
jump
your
off the
hand.
stage again?
Why can't I see it? Oh, I should have known. I should have just stayed over here.
No, that's okay.
You like the questions?
So when you are seeing like physical aggression or what you call it, the neurobehavioral challenges, and you have like the weekly meetings for the Dignity Team, if we don't have that in place, how do you, I know you said you communicate that through email and everybody's aware, but what are like examples of how that works? So yesterday I eval'd somebody similar to this, and it's going to be challenging for nursing more so than therapy when they're off staff and they have other patients to manage. So what does that look like for them? I guess just more information or more examples.
Yeah.
Can you give me that?
Are you asking like specific to physical? If somebody is.
More like impulsivity, not
yeah.
able to, like
See a lot
global
of that.
aphasia, things like that, where they're getting up, moving, constantly setting off alarms.
Yep.
And like, do you put that, does that increase their acuity and then you have more
Yes.
staff? Yes.
It
okay.
does. We see a lot of impulsivity, a lot of impulsivity at On With Life. And I think every person's different, so it's really hard. For us, we look at dignity of risk as well. Are they impulsive, but are they pretty stable on their feet? Can we, so if they're not, but that's a consideration because we have some people that are more impulsive, but they might be pretty steady on their feet. So then we have to look at, okay, do we want to put all these interventions in place that are actually going to affect their ability to have appropriate rehabilitation? Or can we maybe wiggle a little bit to not restrict that and give them a little bit more freedom? If they are not safe to ambulate, we're a little bit different in that we do have some other safety measures in place that we implement at On With Life. We do bed and chair alarms just because it helps us. If somebody has a brain injury and they're missing a bone flap, we need to know if they're getting up. So we do have other safety measures that we use. But even before we'll do a bed and chair alarm, we might put signs up in the room that say, stop, call for your nurse before you get up. making sure that they know how to use their call aid and can use it appropriately, that it's always in reach. Looking at, is their room safe? If they were to get up, is there equipment close by? There's a lot of other considerations that we look at before we even go to alarms. Talking a lot about it in therapy sessions, making sure we're educating every time we're in the room is really important too. If we have somebody that is impulsive and really not safe, we may put a video, we do have some video monitoring opportunities that we can use. Otherwise, there are times where we maybe just need to pull a staff member and do one-to-one. So it can range.
How do I, as a therapist, champion for nursing staff when it's like a system that's 6-to-1? And I can't just, you know what I mean? Like we have 6 patients to 1 nurse and then a CNA.
Yeah. It's hard. I don't know, what all of your staffing ratios look like. I do know we work together as a team, so if somebody needs a one-to-one, and from a nursing standpoint, our staffing ratios that day are not great for a one-to-one. We do reach out to our therapy team members, and they'll try to move their sessions around to help with that too. It really is a team effort. It's not just, okay, this person needs one-to-one nursing, you figure it out. We do reach out to other departments, especially our therapy team members, and they will restructure their sessions if they can to help with that. Sorry. Oh, yeah.
Can I also add? Okay, so a couple of the things that we do, like process-wise. So for us, we do 15-minute safety checks instead of 30-minute safety checks. So every 30 minutes, the CNAs will check on them, and then the off 15 minutes, nursing will check on them. If it's somebody that we can maybe get them to stay in bed, right? Before we escalate to having to do a one-to-one. We also utilize family a lot too, if they have family that's available, especially on those off hours when therapy's not in the building to help. Do they have a family member that's willing to come and sit with them and maybe distract them? What else do we do?
Sorry, it's right here. I mostly work night shift, so when in doubt, if therapy's not in the building or we don't have a lot of leadership on staff, when in doubt, we're just really thinking about the safety of the person served and trying to pick an intervention that is the least heavy intervention for them. So we do low bed with mats. That's another one that we've used. We've used plastic side rails with cushioning on them, so if they're in bed and they're trying to get out of bed, maybe that will deter them from getting out of bed. So it's the littler things that we can try on the night shift as opposed to when everyone's in the building during the day, and then we can have that bigger discussion the next day. So it's really just keeping the person served safe as much as we can on the shift that we're on, and then discussing it at a different time, and then just trying to utilize the staff that we have that's on staff, seeing if we could bring someone in quickly. Maybe our on-call, we can call and say, we're really having an issue. What can we do? What intervention can we start? It's just the communication aspect of it is the biggest part of it, and making sure that that person served is safe no matter what.
Thank you.
You guys, real quick, I want to thank all the representatives from the On With Life inpatient nursing team for joining us today. I had a feeling that a lot of people would have a lot of questions for these guys, so please, if you want to continue conversations, please refer to information in the programs or the registration form. We can always connect you one-to-one with anyone up on stage if anyone in the audience has more questions. So thank you very much, guys. Can we give these guys one last round of applause? We're gonna have about a 10-minute break. We're going off a little bit, shifting a little bit off of the schedule, so we're gonna cut this break down to just about 10 minutes. I do wanna let you know that lunch will be served immediately following Dave Anders' presentation. What I am gonna ask is that when we're done with that presentation and we dismiss you, I'd like everyone to leave the room at this side, on this side of the building, or this side of the room, which is room 106 on that side. Go out those doors. We'll have 2 lines at the buffet table to grab your food. Come back in at one of these middle or further doors and return, and we'll continue the presentations while you guys are eating lunch. So thank you. If anyone has any questions, just come find me. Thanks.